So our next speaker is Dr. Jonathan Quick, and he's going to be speaking about why universal health care is a women's issue. Dr. Quick is a president and chief executive officer of Management Sciences for Health. He's a former director of essential drugs at the World Health Organization and a faculty member at Harvard Medical School and chair of the Global Health Council.
Thank you, Michelle. Good morning. 30 years ago, I was practicing family medicine in a small rural hospital in Oklahoma, in the southwest of the U.S. I was providing family planning, primary care, treating the occasional snakebite wound or gunshot wound. The thing I liked the most was delivering babies. That was before my wife Tina and I had the first of our 3 wonderful daughters. What I liked the most was being with families to bring new life into the world. Sadly, my most vivid memory from those years was a baby girl that didn't make it. The first time parents, young couple, didn't see the warning signs of reduced fetal activity. When they came to the hospital, we reacted too slowly. That couple was counting on us, and we failed them. The Millennium Development Goals have achieved hugely positive impact for women and girls. But as a global health community, we continue to fail those who count on us. We fail the 200 million women each year who can't get the family planning they need. We fail the nearly 300,000 who die in pregnancy and childbirth. We fail the nearly 700,000 who die from breast cancer and cervical cancer. The majority in low and middle income countries where women die younger and faster. What's the answer? For many of us involved in the post-2015 discussion, the answer is universal health care. Now, there are enthusiasts who say, great, but they're skeptics who say UHC is impossible. UHC won't help women. There's nothing we can do for UHC. Impossible? Ask Dr. Siddiqui. When the Taliban, when a conservative government was chased from Afghanistan, chased from power, in 2000, there were no female health workers active, virtually no female health workers active anywhere in the country. Immunization had fallen to less than 20%. 9 out of 10 women delivered without a skilled birth attendant. 9 out of 10 women on their own for labor and delivery. As the first Minister of Health, Dr. Siddiqui could have started building hospitals in the cities. That would have been politically quite appealing. She didn't. She set a vision for universal health coverage with a focus on women and girls. At Management Sciences for Health, we had the privilege of working with Dr. Siddiqui and with others to help realize that vision by first setting out an essential package of health services and by training hundreds of community midwives like Medina here. Thousands of community health workers, half male, half female. By 2010, family planning had doubled, reaching heights greater than some countries that had been at it more than a decade. 150 fewer children, infants and children, were dying each year. And maternal mortality had been reduced by 2/3. Impossible? Ask the people of Mexico or Thailand or Ghana or Rwanda or any of the other 24 low and middle income countries that have achieved or are on their way to universal health coverage. In each country, the pace and the pathway is different, but the vision of providing essential services for all without impoverishing people has been the same. UHC won't help women? It will. Lucy Sakala was a colleague of ours at Management Sciences for Health. Lucy worked in her home country of Malawi as an AIDS counselor. At a very young age, she was diagnosed with cervical cancer. When Lucy was counseling a patient who tested positive for AIDS, she would say to them, "Live positively, I do. There's some things worse than AIDS, like cancer." There was no treatment available in Malawi, and what Lucy could get in nearby Zambia was too little too late. She died at 28, leaving a husband and a wonderful 8-year-old daughter. Lucy wanted her story to be told. If Malawi then had a universal health program, Lucy could have been screened and treated early in the disease. If Malawi had had a program like Rwanda has set a vision for, universal access, universal coverage with a cervical vaccine, HPV, Lucy may never have gotten that cancer. Universal health coverage is the one approach that addresses all of the health needs of women and girls: sexual and reproductive health, infectious diseases like AIDS, chronic diseases like cancer. There's nothing we can do. There's a lot we can do. Already, visionary leaders, visionary ministers of health like Dr. Siddiqui in Afghanistan and Dr. Binawahu in Rwanda, visionary women leaders are in the forefront of universal health coverage. Women at each point in the design and implementation of universal health coverage with voice and influence will ensure that those programs are designed in a way in which they really achieve impact. And if governments and health programs don't deliver, hold them accountable. If they fail, hold them accountable. Yesterday, we heard the amazing story of the Philippines. 6 months ago, the activists were celebrating their victory in the Philippines. In March, the High Court, as we heard, suspended implementation. But there is no question that the activists will win, as they always do in the end. So, Miriam here from DR Congo and her entire generation are watching us. Like that young couple in Oklahoma 30 years ago, they're counting on us. We can't fail them. We failed women and girls far too many ways, far too often. We can do better. We must do better. We can work to make universal health care, universal health coverage, a reality everywhere in a way that provides for all of the needs of women and girls and protects their sexual and reproductive rights. That is a victory we could all celebrate. Thank you.